Good morning for everyone. My name is Eszter Szőke, and let me introduce my PhD topic, which is aspiration in the tracheostomized and critically ill, diagnosis and prevention of complications associated with dysphagia. I'm a speech and language therapist at Semmelweis Hospital at Neurology and Intensive Care Unit, and at Semmelweis University at Intensive Care Unit department. My vision is that speech therapists and physicians work together for their patients, and my mission is delivering an evidence-based speech and swallowing therapy and diagnosis for all patients. You can see there my two specific goals. The first one is comparing the modified Evans Blue dye test to fiberoptic endoscopic evaluation of swallowing in diagnosing aspiration in tracheostomized critically ill patients. It's a systematic review and a meta-analysis. The problem is that dysphagia is common among critically ill and neurological patients with a high rate of aspiration, which can cause pneumonia and can lead to prolonged hospital care and slower recovery. So if screening aspiration lacks, the pneumonia incidence will be higher. We know several diagnostic methods to assess dysphagia. There are invasive and non-invasive ones. In the first and second picture, you can see the FEES, the fiberoptic endoscopic evaluation of the swallowing. It gives us real-time visualization, as you can see, about the swallowing. But we have to get some special knowledge, for example, how to use an endoscope, and sometimes it can be a little bit uncomfortable for the patient. The other one is modified Evans Blue dye test, which is a screening test for tracheostomized patients. You can see in the third picture, we give colored bolus or liquid for the patient, and if we see this in the cannula, the colored bolus, it means the patient has aspiration. So the missing link is that the quality of the evidence of the blue dye test versus FEES in tracheostomized patients, and the aim is to defining whether the blue dye test or the FEES is the most reliable and feasible diagnostic method in tracheostomized critically ill patients. Our clinical question is the blue dye test as accurate as FEES for assessing aspiration in tracheostomized critically ill patients? We use the PIRD framework. The population is the tracheostomized patients. The index test is the modified Evans Blue dye test. The reference test is the FEES. And diagnosis is the aspiration. Our hypothesis is blue dye test is not inferior to FEES in diagnostic accuracy. Our clinical implication is dissemination of the blue dye test for all tracheostomized patients of all intensive care units. You can see there our search key, and finally, after the selection, we found 6 eligible articles. All of them are observational studies. The first outcome is sensitivity of the modified Evans Blue dye test versus the FEES, which is 0.64. And you can see there 2 outliers, which is Philo and the Warnecke. They performed the test, the FEES and the blue dye test, at the same time. The blue dye test specificity is 0.89, and the outlier is Belavsky. They involve ventilated patient with minimized pressure support. From the clinical decision-making side, important outcomes are the negative and positive predictive values. The negative predictive value of the blue dye test is 0.59. It means that blue dye test is non-reliable to confirm true negativity of aspiration. And the positive predictive value of the blue dye test is 0.95, which means that the blue dye test scale is reliable to confirm the true positivity of the aspiration. You can see there our conclusion based on our results. So if the modified event blue dye test is positive, so the patient has aspiration, the patient can be fed orally and cannot be decannulated. So we need to find some alternative feeding methods, and we should keep the cuff inflated. But if the blue dye test is negative, we should perform the FEES. So if the FEES is positive, the steps are the same as blue dye tests. But if it's negative, we can feed the patient Peros, and the patient can be decannulated. The strengths of our study is these are directly informs bedside practice and immediately translatable into practice, but there are some limitations because there are relatively small and heterogeneous patient population. Our latest submission is to scientific reports, and based on our results, our second project is the practice of the modified events blue dye test to assess dysphagia in tracheostomized patients in the intensive care unit. It's an international survey. As I mentioned you, the modified events blue dye test is a simple, non-invasive and inexpensive swallowing screening test, and it not requires prior knowledge. So when we don't have radiographic or fiberoptic procedures, we can use the blue dye test. So the aim of the registry is to determine the appropriate method for performing the modified events blue dye test. In the articles, we have found so many differences in the methodology. All of the articles you deflated the cuff when they are doing the blue dye test, but some of them, the Belavsky article involved ventilated patients who got minimized pressure support. And you can see there the studies use several consistency. Most of them are use water, but there was eye chips, saliva-like consistency, honey-like consistency, and jelly too. So the survey questions is about the respondents' characteristics, the preferences, the testing, who used the FEES, the blue dye test, or other swallowing diagnostic methods. And we ask about the methodology, how the respondent performing the modified events blue dye test, and about the further steps in case of positive or negative blue dye test. The data collection is by email, and we send it to several organizations, and we bring to conferences. So now the data collection started at 29th of May, and we have 27 completed responses. Unfortunately, so far 3 participants said that they are use modified events blue dye test. You can see below that they use the FEES too. One of them just the blue dye test, and they use food dye. They performed the test with the deflated cuff, and they did not perform this with ventilated patient. So you can see there my progress of the survey, and these are my 2 ongoing projects. And we are very grateful because we can present our findings in 2 conferences. I would like to thank you for your attention with the quote, "The beginning is always today."
I was curious about assessing the aspiration. Is it a yes or no question? Or do you quantify somehow how much a patient aspirates? Or?
In simple, it's a yes or no question. I came back. But maybe it's a complex diagnostic method, because with FEES you can see the patient has aspiration or not. So as you can see in the picture, the patient's bolus get below the vocal cords in the airways. So it's a yes, the patient has aspiration, but with screening tests we have, it's harder for us because sometimes with the blue dye test when it's positive we can see, but if the patient has aspiration but the modified blue dye test doesn't show us the blue color, we can tell the patient don't have aspiration. So it's based on things like that. So speech therapists like me, we are not diagnosing just the aspiration, but we are want to know how the orofacial movements works. Is there any problem with, for example, the tongue movements or the elevation of the larynx? So it's I think it's a more complex, yeah.
In your practice, which one do you use more, FEES or the blue dye test, and why?
Usually I use modified Evans blue dye test, but it's because in Hungary we don't have any training how to use FEES, so we don't have FEES trainings, and in the university we don't have any education about how to diagnose aspiration in tracheostomized patients. When I started to work with them, the blue dye test was the only method for me to diagnose aspiration. But we started to learn with my colleagues, medical doctors, how to use the fibroscope, but we have to do some foreign trainings and after that at home. So it's not as easy as like in, I don't know, in Germany or in Austria. So I'm using the blue dye test in the in my daily practice.
Seeing the results of the survey, this is the first time I'm seeing the actual numbers. It's quite discouraging, let's say, discouraging, because I would expect more physicians actually perform the blue dye test. It's, as you said, it's cheap, it's very practical, and it doesn't really need any further education about this. And I know that from your clinical practice, you do use the blue dye test, and thanks to you, I also now use the blue dye test. But why do you think people are not using this? There is literature about it. It has been done for many years now. Why are medical doctors not performing this very common sense and logical test? Is it just ignorance?
I think we have not many data, not many articles about the modified Evans blue dye test, and so I think so many doctors, for example, don't have information about how to perform the test. They don't know about the blue dye test, and most of the cases in Hungary, I think the doctors, if there is any swallowing problems in the intensive care unit, the patient, what they can decide the patient has aspiration or not, they will call the otorhinolaryngologist to tell them is there a patient or dysphagia or not, or feed them or not. But we don't have so much speech therapists in Hungary in the intensive care unit, so I think it can be very important because they can not just in diagnostic but in therapy too. So I think, or I hope they will use more the blue dye test.
Maybe we should share the YouTube video of your talk, and then more people will use it. So congratulations for you as well. And I have just a small question, and again, everybody argues that it's a quite difficult position to answer in front of so much people. So try not to be too anxious. My small question is, you mentioned sensitivity, specificity. What is the meaning of sensitivity and specificity? And in your application, which one is the more important? Because it's frequently happen that sensitivity and specificity, the importance is differ across fields, basically. In your field, which one is more important?
So the specificity, you can say it's 0.89. Which means us that, for example, we have 100 patients, and it's a rate that they can 89% will be negative to assess the rate of the.
And the 100 person are. So what is specificity? It was quite good that you said. Just we have 100 watt person. Specificity, which is the denominator in specificity?
The negative among the healthy.
Yes, good. Thank you very much.
Okay.
I don't understand clinical words, sorry. But not always I understand.
I'm just a little bit. And the sensitivity is the positive among the healthy peoples.
Wait. Sensitivity is the positive among
the
diseased
people. So it shows us how they can identify the true positivity of the patients.
Good. Thank you. And which is the more important in your application? What do you think?
I think both of them are important. I can tell, and the sensitivity and specificity can't be with each other. So I think both of them are important.
Okay, thank you. And I have now a remark. I don't have more statistical question. Thanks for the good answers. Thank you very much. And
thank you.
I have just a remark, basically, because it's also a progress report, not just an exam. And I saw PPV and NPV pools, and we don't like it in meta-analysis too much to pull them because they depend on the prevalence. So how different the prevalence in this case? If they are different, then maybe it's not a good idea to pull NPV in this way. This is just a comment, not a question, rather, that we prefer sensitivity and specificity meta-analysis since they don't depend on the prevalence in the population of the disease. PPV and NPV do depend on the prevalence. So if the prevalence is too different, then maybe it's not a good idea to calculate pooled PPV and NPV.
Okay.
But we can discuss later. I just mentioned this issue that can maybe improve a little bit the thing.
Thank you so
and
much.
Finally, I like your sentence in the end that each day is a new day, basically.
Yeah.
And the room is Marcus Aurelius' room, and we know about his Stoic philosophy. And part of the Stoic philosophy is be present and don't worry about the future and don't think about the past, basically.
Yeah.
So congratulations again.
Thank you so much.
Thank you for your very interesting and especially clinically relevant studies. Yeah? Because this is actually how these tracheostomy patients are going to die. They aspirate, they suffer from pneumonia, they get sepsis, and then they die. Would it, or have you read, would it improve the relevance of the investigations if they are done on randomly 3 days or something like that? Because, you know, we have good and we have bad days, and so do our patients. So a negative result for me as a clinician of aspiration risk might not hold true for a whole week. Yeah? I would like to have these patients investigated on day 1, 3, and 4 to increase my knowledge about that. And my second question is, have you any ideas how you have a finding, how you could improve anything thereafter?
You mean how can I improve, for example, the modified Evans blue dye test when I'm performing?
If you find an aspiration.
If I found the aspiration. When I found aspiration in the patients, I have to know which consistency the patient aspirate, because I see sometimes there are problems with the liquid, but no problem with basic consistency or other consistency of the boluses. So in this case, we have several, for example, compensatory strategies, and we started the therapy to work with these muscles, and they can help for the patient to swallow more safety and to improve the muscles' strength.
It's just an idea, because we see this problem very often, not only in tracheostomy patients, but also in the ones who stay for very long with us on the intensive care ward. And we use esophageal stimulation via the vagal nerve, which helps quite properly. Yeah? So I do see this very often, and we do this test, and we have our speech therapists and so on, but we would like to we proceed quicker.
Yeah.
In terms of the ICU patients, we know very well they can be quite diverse, and just to increase the acceptance rate among the physician, for example, to apply this method you presented. So can you define a special or selected patient group who have the most benefit, for example, to use this test, just to increase, the acceptance rate?
I think it can be for all the patients who has tracheostomy.
Okay, but majority of the patient has a reversible cause or etiology of this, so
we see that there are, for example, stroke patients, or they get a tracheostomy after any traumatic injury. But in the articles, we didn't have enough information about the patients. But I think the modified blue dye test usage is not depends on totally from it's a stroke patients or in another. Or I hope I understand well.
Maybe the length of the mechanical ventilation, the period on the length.
When we use it, it's not good for ventilated patients, and we should wean them off from ventilator before you use the test.
Okay, thank you so much.
Sorry.